Hello, everyone. I'm Winchester Cody Wiley, and I'm currently a nursing student at Franklin University. We're in 790 in the last semester, and we'll graduate with our FNP. Joyce Aquila is our instructor, and today I'm going to be presenting on mental health needs for special populations in primary care. We'll cover 5 key groups: the elderly, geriatric, frail elderly, pregnant lactating individuals, pediatric and adolescents, LGBTQ+, and individual immigrants and migrant workers. For each, I'm going to discuss the epidemiology, prevalence, evidence-based assessment, and screening tools, treatment, care planning strategies grounded in current guidelines. So without further ado, let's get started. So as our population gets older, mental health issues in older adults becomes increasingly significant. According to the World Health Organization, or the WHO, in 2025, estimated mental disorders account for about 6.8% of years lived with disability in adults over 70. Depression is particularly common, with the prevalence ranging from 10 to 29% in communities and long-term care settings. Major depressive disorders around 10%, and depression symptoms up to 29%. Anxiety often co-occurs with the rates increase with age and frailty. For elderly individuals show higher rates of depression, apathy, and distress. Economically, untreated conditions contribute to high health costs through hospitalizations, falls, and comorbidities. Projections show the number of older adults with psychiatric disorders could double by 2030, straining primary care resources and having an influx to the people that have served our community for so long, and they deserve the best treatment and care that we can provide them. So for assessment and screening, we'll see what are gold standard tools. They remain the same. Geriatric Depression Scale, or the GDS, either the 15, which is the short one, or the 30, which is the items long form. It's yes or no in a format minimize systematic bias and highly validates for older adults. The GAD-7 is effective for anxiety, and the PHQ-9 serves as a reliable alternative. DSM-5 considerations include focusing on present low mood or anhedonia while differentiating from grief, dementia, and medical causes. The USPSTF reaffirms a B recommendation for depression screening in all adults, including older adults and primary care settings. Annual or opportunistic screenings is key, especially for frail and isolated patients, combined with cognitive screening and if indicated. So in our older patients, it's super important to assess, their living status, how they're feeling, how they're doing, and you're going to see these people coming in and out of the primary care setting all the time, and we're first line in helping these individuals. The GAD-7, PHQ-9, the 15 and the 30 are something that we use pretty common. So, treatment. First line treatment, anxiety and depression. SSRIs is the first line pharmacotherapy. Sertraline or escitalopram is preferred due to lower anticholinergic and fall risk. Start low and go slow, given age-related pharmacokinetic changes like reducing renal hepatic clearance. Monitor side effects including hyponatremia, QT prolongation, and increased fall risk. We're going to avoid TCAs and benzodiazepines. The Beers criteria rules those out just because they have so many common side effects. Evidence supports psychotherapy such as CBT, problem-solving therapy, or interprofessional therapy, often as first line for mild cases. Collaborative care models integrating pharmacokinetics, social workers, and geriatric specialists to improve outcome. Follow APA and USPS TFC guidelines emphasizing safety and multidisciplinary approach. So going back to the medication, I'll give you a scenario that had just happened to me. It doesn't have to do so much with psychiatric pharmacotherapy because I'm just getting new into this as an FNP, but I'll give you an example of a patient we picked up last night that had a hip fracture. And knowing that the clearance and the half-life and how they metabolize drugs indicated a lower dose. Normally we give like 0.5 ketamine per kilogram to 1, and we gave 0.25 as well as an Ativan, and that was the exact right dose. Anything more would have been over sedation and analgesilized. So just think about that when you're prescribing medications and your SSRIs. Of course, follow your guidelines with Hippocrates and all the things that are recommended. So, the pregnant ladies, everybody's favorite, especially mine. I have 5 children and a beautiful wife, and I'd love to start talking about this. Parental mood and anxiety disorders affect approximately 1 in 5 women, making them one of the most common complications of childbirth. Postpartum depression has a global prevalence of around 17 to 18%. Untreated, these conditions lead to significant economic burdens estimated at the billions annually in the U.S. due to lost productivity, increased healthcare utilization, and long-term impact on children, development, and maternal-infant bonding. Postpartum depression is a real thing. I've seen it, and it's definitely something that needs to be addressed and looked out for. There's a lot of hormonal changes going on, especially if they have a pre-existing underlying depressive state. Screening. Screen universal using the Edinburgh Postpartum Depression Scale, or the EPDS, the gold standard for perinatal depression and anxiety, with a cutoff of 10 to 13 indicating need for further evaluation. PHQ-9 and GAD-7 serve as adjuncts. DSM-5 uses a prepartum onset specific ACOG recommends screening at the initial prenatal visit, later in pregnancy, and at postpartum check-ins. Early repeated screening reduces stigma and improves detection. Pharmacologically, SRIs like sertraline are preferred for their safety profile in pregnancy and lactations. Balance risk with benefits, monitor infants for adaptation issues, avoid paraproctine due to potential cardiac risks. Psychotherapy options include CBT, interpersonal therapy, and mindful-based approaches, often first line for mild or moderate cases. Collaborate care with parental mental health specialists, lactation consultants, and support groups is essential. ACOG and USPSTF guidelines strongly support integrated screening and treatment to optimize maternal and infant outcomes. Yeah, these ladies are already under a lot of stress as it comes, and we need to do everything that we can do to help them. The SSRIs are really good for anxiety and depression, and they're first line for just about all of that. So to babies, pediatrics, and adolescents. Mental health challenges in the youth are rising. Nearly 1 in 5 adolescents experience a mental health disorder each year, with anxiety and depression prominent. Suicide remains the leading cause of death. Post-pandemic increase have amplified this. Long-term economics include lost education, attainment, productivity, and higher lifetime healthcare needs. Early intervention is cost effective. I don't want to get on the soapbox about social media, the loss of religion, social isolation, but there was a whole generation that we sure did a disservice to in the preceding 4 years, and what they were pushing the narrative, and it's our job to help these children out as much as we can. Assessment. Using validated tools like the PHQ-9 for adolescents, the GAD-7 for anxiety, and the Columbia Suicide Severity Rating Scale for suicide risk. DSM-5 criteria adapted for age. Irritability may predominate in children over sadness. The USPSTF recommends universal screening in primary care involve parents ethically while respecting adolescents' confidentiality. I mean, they're not little adults, and then their brains are not fully developed, but we still need to build a trusting relationship with our patients, and we need to involve the parents as needed. Treatment. SRIs such as fluoxetine are FDA approved for pediatric depression, but carry a black box warning for suicidality. Cause monitoring is required. Psychotherapy is first line. CBT, family therapy, or dialectical behavior therapy. Integrate school resources and pediatric mental health access programs. The AACAP and APA guidelines emphasize therapy before or with meds for moderate severe cases. So the black box warning on the suicide medication is because they feel better. It's still, if it's needed, we need to absolutely prescribe the medication if cognitive behavior therapy is not working, and they just need a little bit more help. And it could be for short term or it could be for long term. We just need to emphasize that, it's not their fault. This is a disease, and that we're going to help them get through it however we can. LGBTQ. Individuals face 2 to 3 times higher rates of depression, anxiety, and suicidality due to minority stress, discrimination, and stigmas. Recent surveys show significant higher mental health services utilization and needs compared to heterosexual peers. Economic impacts include healthcare disparities and loss of productivity. Standard tools like PHQ-9, GAD-7 work well. Add questions on minority stress, discrimination, or trauma. DSM-5 encourages culture formulation, create a safe, affirming environment with inclusive language to improve disclosure and accuracy. Pharmacological options follow general guidelines. SSRIs or SNRIs is first line. Psychotherapy approaches could be affirmative by cognitive behavioral therapy, adapted for identity affirmation, acceptance, commitment therapy, refer to LGBT content providers as support groups, APA and WPATH guidelines stress affirming culturality, responsibility, care to build resilience. I think that we need to let people be people, and we should be an open ear for them, and SSRIs and SNRIs, and just letting them talk and making sure that their life choices are something that they are comfortable with and that they want to continue, or giving them different options and just being an ear and referring them to the right people. Is always super important. Immigrant workers. Hot topic in 2026. Immigrant and migrant workers experience elevated rates of depression, anxiety, PTSD, and sleep disturbances due to trauma, culturalization, stress, discrimination, and access barriers. Meta-analysis shows pooled prevalence around 20 to 35 depression is similar for anxiety, often unreported. Economic costs stem from lost wages, untreated conditions, and productivity impacts. We use the PHQ-9, the GAD-7, and translated and validated versions, or tools like the Harvard Trauma Questionnaire for Trauma. Consider culture syndromes and DSM-5 formulations. Employee interprets trauma-informed approaches and build trust. Community-based screenings help overcome barriers. These people go through a lot. We need to be there to help them. SSRIs are first-line pharmacologic monitor and adhere to trauma-focused cognitive behavioral therapy or narrative exposure therapy are evidence-based, collaborative with community health workers, culture-competent teams, social legal services, WHO guidelines emphasize address social determinants alongside clinical care. I hope y'all enjoyed this. This is a list of all the references on here. But in summary, it's a tailored approach to screening and collaborated evidence-based care essential across the special population to improve outcome in primary care. Thanks for y'all. I'm happy to take. If y'all need anything, you have my email, my phone number. Y'all be blessed.